I've been given the task of talking about, I don't have a crystal ball with me, I left it at home, but how we'll be treating epilepsy in 10 years' time. On the one hand, maybe I'll disappoint you and say, well, maybe we'll be treating epilepsy in 10 years' time much the same way as we're treating it now. Certainly, a lot of the basics will be the same, but on the other hand, we can see that there is a lot of changes coming through. There are challenges, both in genetics, but a lot can happen in 10 years. And we just heard that these microRNA particles were known about 10 years ago. So that's one demonstration of the fact that something can change dramatically in 10 years from a scientific point of view. So I'm just going to touch on a number of areas. Some of these are relevant now and are evolving. I'm going to try and go quickly. No matter what happens in the next 10 years, we are not going to replace the basic, hopefully good quality doctor-patient, clinician-patient interaction. That's the basics. I mean, no test is going to replace this. Some people thought when MRI came or all this fancy imaging, we get a whole body scan and don't bother even talking to the doctor. It doesn't work like that. So a good quality history is really important, and communication between the clinician, be that the doctor, clinical nurse specialist, and the patient is really important, and patient education is important. And that's not going to change in 10 years, and it's not going to change in 100 years. Okay? Resources. I feel strongly about this. I know my friend and colleague in the audience, somewhere, Brian Garrity, feels strongly about this. We don't have enough epilepsy resources in Ireland. I mean, I think that's no surprise to you, but it's you know, if you compare it with other what are supposed to be what are developed European countries, we are lagging behind. We do not have a fit for purpose complex epilepsy centre. We have a number of epilepsy units in the hospitals, including Beaumont and CUH and Temple Street, etc. But we don't have the complex epilepsy centres that they have in Switzerland, in France, in Germany, in the UK, Chalfont in outside England, for example, Quarriers now outside Glasgow. So there's really no point in all these fancy thingamajigs if we can't get patients in to see their doctors, and if we haven't got enough resources. We still don't have enough neurologists in Ireland by far. I mean, we're still down at the lowest rung. Who's the bottom of the Premiership at the moment? Burnley. We're still the Burnley or whatever, maybe even the Newcastle now of Europe in terms of where we are with the numbers of specialist neurologists, but treating general neurology problems and epilepsy problems. We're still bottom of the ladder in Europe in terms of head of population. So there's really no point in this. We might as well go home if we don't get the resources right. And this needs to change. It has changed a little bit over the last number of years. We do have to give the government credit. We do have to give the advocacy groups, including Epilepsy Ireland and the Neurological Alliance of Ireland, credit in terms of moving this forward. But we are still way under-resourced in this country. And similarly in pediatric neurology, there's still only, 5 or 6 pediatric neurologists. If you go to an academic medical center in the United States, there will be a whole army of specialists in one hospital. I mean, 20, 30 specialists in one hospital. Okay, I got that off my chest. I always have to get it off my chest. Brian and I believe that there needs to be a national epilepsy centre in Ireland. We still believe it will happen. And watch this space. 10 years' time, still the basic tests will be EEG and MRI. I believe that's really not going to change. Another basic test, probably for lots of patients in 10 years' time, once we get through all the hurdles and challenges, and there are many, will be an exome sequence scan that we've heard about. Okay, and these will probably be the 3-pronged approaches for new onset epilepsy patients and patients with difficult epilepsy. And by the way, there's all different types of EEG, but video EEG is the gold standard. The amount of information we get from an inpatient video EEG monitoring evaluation is just unbelievable in terms of the knowledge we get from that. We've heard about this. I'm not really going to repeat it too much. I'm going to sort of, but you can. So in 10 years' time, we would like to think that the patient will be able to have a DNA fingerprint blood test analysis, i.e. an exome sequence, a genome sequence. This will become affordable and cost-effective. We've heard already from Mary that there's clear arguments already, apart from all the information we get, and and the value of giving a diagnosis to a patient and a family. There's clear evidence already that this actual approach will be cost effective because it will be obviating or avoiding a lot of tests that really yield nothing. Okay. We will also envisage in 10 years' time that this complex set of individual genomic information will be securely stored and will also be available for the future healthcare needs of that individual patient related to the epilepsy and perhaps then other conditions as the patient gets older through life. There's even talk about, it's probably a brave new world, where every baby, at birth, a baby will have their genome sequenced, and that sequence information will be available for the healthcare needs of that individual's life from there on in. This is happening. And there's then also the challenge of big data, the amount of, if you've got such a complex structure as the genome with 23 pairs of chromosomes and 3 billion base pairs, then this generates a lot of data, and this data needs to be managed. The world is all about big data now. I mean, people are analyzing every time you go on the internet, train times. I met somebody in the airport the other day who was over in England, and he's a data analysis. He's doing analysis for some train company. Every big company wants to know about data. And of course, Google are taking over the world, and they want to know about data. Everything is about big data. Okay, so genetic analysis, we've heard it, will determine a change in an individual's DNA, which may help determine cause of epilepsy, predict response to various drugs, predict side effects, and predict prognosis. Wouldn't it be lovely if we could do this in 10 years' time? So at the moment, we have developed, with support from the Health Research Board and with the lead taken by a colleague in Beaumont, Mary Fitzsimons, we have an epilepsy electronic patient record with a summary of all important clinical data and various different fields that we can then generate into a summary page. But there's a lot behind this, where we can go into different pages and look at, for example, the medications that a person was on before to try and treat their epilepsy, the reason, the date when the doses were changed, and the reason why the medication was stopped. But can you imagine in 10 years' time, not only could you click on the clinical data part of the electronic patient record, you could securely connect on the patient's genome, which would then in some way for the clinician would be interpreted to read out a list of important variants or mutations that we heard about that may help us guide treatment again that we've heard about. And not only that, wouldn't it be lovely that you yourselves, the patient themselves, could actually take part in their own care and contribute to their own care by use of, for example, a smartphone app which would beam in their patient data, like their seizure record when they had a seizure, change of medication, side effects. So you could click on a patient, enter data, and so then you'd have the whole gamut of information that one would need to treat a patient optimally. A challenge, but again, this is what people are talking about and thinking about. This is just a slide that's shown at every international epilepsy conference to show that the amount of anti-epileptic drugs has been increasing, particularly over the last 10 or 15 years. Still, of course, there's a huge unmet need for more effective anti-epileptic drugs, and we've heard about tailored therapy, which we'll talk about. By the way, Jean-Pierre is going to come down in a minute, halfway through this talk, to go back to something that Tracy would have talked about just for a few minutes. There are still new drugs being developed, so in 10 years' time there will be more new drugs for epilepsy, but this is challenging, and the pharmaceutical industry really have been turned off a little bit about trying to develop new anti-epileptic drugs in the old traditional clinical trial model for a variety of reasons, because it's becoming much more challenging to do that, partly because there's so many drugs available already, so the clinicians will not be willing to put their patients into a placebo arm of a clinical trial. But there are new strategies to develop drugs being developed. There are some examples of drugs that are coming down the track, so to speak, that are not yet available. Mostly. This is brivaracetam, which is a chemical first cousin of levetiracetam, or Keppra. This is another novel compound which may or may not make it. This is a compound derived from a Chinese herb, huperzine A, which has been developed by Steve Schachter in the Massachusetts General Hospital. And of course, there's a lot of interest at the moment in cannabis or marijuana extract in the treatment of epilepsy. And again, this may or may not make it to the sort of playing field in 10 years' time. Already, of course, you will know that there is orphan drug approval in the United States for a non-psychoactive cannabis extract called cannabidiol, which has been given orphan drug approval by the FDA for the treatment of some of the severe childhood epilepsies that Mary talked about, including Dravet syndrome and Lennox-Gastaut syndrome. There has recently been an open label trial in some of these children published, which suggests that this cannabidiol extract may help some of these young children. The summary actually is on the Epilepsy Ireland website front page at the moment if you want to read it. But, you know, like everything, these things need to be thought about properly, but may have a role for some individuals. Okay, another thing, just to point it out to you, that may happen over the next 10 years is that people are looking at devices. We've heard David talking about, and he's absolutely right, one of the huge problems about epilepsy is we can't predict when seizures are going to happen. I always say if you had one seizure a month but knew it was going to happen on the first Thursday of every month at 4 p.m, then you could say to your boss, I'm off home, I'm going into bed, I'm going to have my seizure at 4 o'clock, I'll see you in the morning, or it's Monday. So that would be grand. But so there's now, people are looking at implanting devices into parts of the brain that will, for that patient, detect a signature of brain waves that is pre-seizure, if you like, and then that will read out to the patient that in the next 4 hours you are 90% likely, because nothing is ever 100%, you are 90% likely to have a seizure. So then the patient can act on that information and inject some perhaps medication, maybe a small bit of midazolam or some other, there's a couple of animal toxins that can be developed locally that are anti-seizure, so that the patient can then activate the device and preempt the seizure. Again, science fiction, people are looking at it. Any of these things, by the way, or lots of these things will be helpful for just a small group of individuals, but it will, if anything that helps an individual with severe epilepsy and their family would be, for that individual and family, a huge advance. It's not going to be like, oh, you've got epilepsy, I'm going to implant a seizure detection device. So, you know, but this is being talked about. 10 years, it may or may not happen. There's a huge interest in devices at the moment, and we know that the vagal nerve stimulator, which is a palliative or kind of helpful but not curative therapy for difficult epilepsy, has been around since about 1997-ish, 97, 98, that's around when the trials were done in the States. But there are some newer devices now, some of which are undergoing approval processes in Europe, or at least some European countries, and also in the FDA, Food and Drug Administration in the States. And some of these devices, for example, there's a device, some examples would be what's called a transcutaneous VNS, so it wouldn't require an implanted operation. And basically, the stimulation is via a nerve called the auricular nerve, which is a branch of the vagus nerve. And then this device is stimulated similarly so that it kind of, if you like, it's a non-invasive VNS. This has been approved in some countries, I understand, in the States, I think in Germany and France. It hasn't, as far as I know, it hasn't been, we haven't used it. It hasn't been approved in Ireland yet, it hasn't been approved in the United States yet, and there's still more what we call efficacy data needed to see if it really does work. And by the way, all these devices, again, will only be useful for a small number of people with very difficult epilepsy, and a lot of the data would suggest that some of these devices aren't really statistically that much better than the traditional vagal nerve stimulator device, but again, we can argue about that, but again, it will help a small number of patients. There's also this very, if I can use the term, sexy device called NeuroPace, or responsive neurostimulation, which was developed by Marta Morell and colleagues in the United States. And the idea of this is that if your epilepsy is coming from a really tricky area of the brain that can't be removed, like for example your language area, then if you can't remove that, because then the person won't be able to talk. So the general idea is that you put electrodes in this area, and when the electrode sees the seizure signal starting, automatically it will develop a local stimulus into the same area to try and halt the seizure, if you like. So this is done automatically by the actual NeuroPace device. It's different to seizure prediction. The patient doesn't have to worry about it. It'll happen automatically. So this is approved in the States, as far as I know now, and will be approved in Europe fairly soon. But again, small number of patients will benefit. It will need centres like ours to train up on it, or surgeon needs to train up on it. It's not as simple as say, device approved, great, it's all. You know, from our perspective, this is a lot of extra expertise that is needed, and we are already stretched in terms of resources. But over the next 10 years, these will come true. At least some of them will come true. Okay. Also, the technology is helping patients. So this is some pages from the new Android phone app that you might have seen on the Epilepsy Ireland website, which will allow you to track your own epilepsy and bring the information to the doctor, maybe even beam it in over cyberspace into the electronic patient record eventually. So these kind of phone apps some of you may already be using. There's other phone apps. There's this epilepsy smartwatch that is now available, and also there's ongoing technology, which probably Sinead Murphy up there sitting down the step knows more than anybody else in the country about the sort of seizure detection systems, which are getting more sensitive. So, you know, if you've got a young child or an individual in bed at night, and you can actually detect their seizures so that an intervention can take place. So a lot of the technology is also going to assist patients directly. Again, I'm conscious of time. We've kind of said this already, but there's this concept of precision therapeutics, which basically means that you can tailor the treatment to an individual person. Because a lot of, essentially, if you go down to the molecular level, everybody has a different disease. Everybody's a different disorder. So the idea here is you define the genetic abnormality, you produce that abnormality in a dish in vitro, in this what's called a microarray system. You then test various drugs in the dish to see if it reverses the electrical abnormality, and the effective drugs then, if they're safe, can go back to the individual to treat that individual. So you're basically testing the drug outside the patient in this dish model, and then going back to the patient to try and treat that patient individually according to their genetic knowledge or genetic profile. An example very quickly of precision therapy that has already been reported is this migrating partial seizures of infancy, which is due basically to a change in a protein called, or a gene is called KCNT1, which Mary mentioned. Again, in the interest of time, basically, quickly, the bottom line is Quinidine, which is a drug that's used for heart rhythm disorders for a long time, can reverse in a dish model, if you will, the hyper or abnormal electrical discharges generated by this mutation. So this is without Quinidine, this is with Quinidine. You can see the abnormal electrical output is changed by Quinidine. And basically, Quinidine has also been used to treat malaria. Basically, Quinidine has been reported in a number of children with this severe epilepsy to have a huge effect on these individuals. When the child is given Quinidine, which has never been used as an anti-epileptic drug, the seizures, in this particular report, the child went from, where am I going? So this is the background information on this child, like 5 to 20 seizures per day, no response to all these drugs, really, really severe epilepsy. And then Quinidine was started in the hospital under careful guidance. At 1 week, seizures stopped. Patient showed improvement in overall head control. Patient spoke her first words. 6 weeks, the seizures began to return. The Quinidine dose was increased. At 7 months, the seizures really only occurred when the patient was stressed, like say with a fever. And in July 2014, this child who had severe epilepsy, which was given a drug that we would never have thought of for the treatment of epilepsy, is doing extremely well on the basis of the genetic profile. So this is where therapeutics is going. I'm going to ask JP to come up and, as quickly as he can, go through the Epilepsy Genetics Initiative, and then I'll come back to close.
So again, this was the initiative that Tracy was going to come over to talk about, but I thought we'd just play a video.
Imagine having the ability to unlock the genetic secrets of epilepsy. Just think of what this would mean for the 65 million people currently living with this debilitating disease and the doctors who struggle to find a way to stop their seizures. Knowing what causes epilepsy and what treatment might work best seems almost like an unattainable dream. But thanks to modern advances in genetic research, this dream is close to becoming a reality. By examining the changes in a person's genes, researchers have been able to identify altered genes that lead to some people's epilepsy. With about 20,000 genes in each of us, this is no easy task. However, by using genetics to diagnose and treat each person individually, we could create a world where we tailor treatments to each individual person with epilepsy. Unfortunately, current gene testing is limited because studying gene data is challenging, and analysis sometimes needs to be repeated again and again over time before we can identify a cause. Now, that's where we come in. The Epilepsy Genetics Initiative, or EGI, is a project of CURE dedicated to advancing epilepsy genetics. CURE has created a place where people with epilepsy, with the help of their doctors, can house their genetic data to have it analyzed and reanalyzed to help find the cause of their own epilepsy and help advance science as it seeks to uncover new causes of epilepsy that have yet to be discovered. Researchers will be able to study the genes which will be confidentially collected in EGI and build a database that has never existed before. Just imagine what this will mean for epilepsy research, therapy development, determining which treatments work best for which people, and discovering why some people with epilepsy suffer from coexisting conditions like depression and learning and memory challenges. By bringing together people with epilepsy, medical professionals, and scientists, EGI will help to improve the diagnosis and treatment of epilepsy in a way that has never been done before. Find out more at www.cureepilepsy.org/EGI.
Okay, so what they're doing is creating this database that anyone worldwide who has a diagnostic exome sequence run. So at the moment in Ireland, it's very, very limited, that amount. I think Professor King has had a couple run perhaps, but it's limited because private health insurers are not supporting it, and the HSE at the moment doesn't have it integrated as a routine clinical test. But in some regions of the world, they are being run, and the idea is that anyone who has one run has the ability, should they wish, to have their sequence included in this database that's then analyzed by different groups of researchers around the world. And those groups of researchers need to be approved by the CURE Foundation, and any group of researchers can apply for that particular approval. And the key thing there is that we need to be able to analyze and reanalyze. And Professor King mentioned that at the moment the diagnostic yield is 25 to 30%. But doing the next round of analysis is really, really tough, because you only get more information out when you understand the data better. And the more sequences that are in there, the better the ability the geneticists have to extract more diagnostic yield from that information. So this is a centralized database. It's about trying to better understand the genetic sequence in the context of epilepsy. How do you get your data into EGI? So for people who are interested, they would contact CURE Foundation. CURE would provide them with all the informed consent information about the study, consent documents, so it's explained to them properly. The doctor would then tell the sequencing center at which the diagnostic sequencing was run to allow that particular sequence to be uploaded to the EGI database. Then what if something is discovered in my DNA? So this is of particular value to people who've had a sequence run, but there's nothing diagnostic coming out of that sequence. The analysts around the world would continue at regular intervals to reanalyze the EGI database. And the expectation is, with time, there'll be new diagnostic calls made on some of the sequences in the database. When they are found, they are fed back to the doctor, who would contact the patient and then explain the particular results to them. What kind of results could one expect? Well, EGI has come up with these different categories. Probably right now, the majority would come back with no cause of the epilepsy is found. But then there will be cases where perhaps a known mutation in a known epilepsy gene is detected. So that might be one that was missed by by the original sequencing center. Or there might be a new genetic change in a known gene, perhaps another mutation in SCN1A. Or there might be a genetic change in a gene related to SCN1A that wasn't previously known to cause epilepsy. And an important one here is sometimes you might find a genetic change that may not be related to the individual's epilepsy, but could have important health consequences where a treatment might be possible to intervene. Okay, back to Norman.
We're nearly there. Now we take questions. I've got a couple more slides about what might happen in 10 years' time. Or what's happening over the next 10 years. So again, it was mentioned by a few speakers about the comorbidity of epilepsy, and I think there will be a greater appreciation of things like depression, anxiety, bone health problems from medication, etc. So this is something that's again more to the fore in treating individuals with epilepsy. There's also an increasing emphasis and interest in holistic approaches to treating epilepsy and other medical conditions. There's an increasing interest in the West, so to speak, in the role of Eastern practice in wellness in general, for example, through mindfulness approaches and meditation. And I believe that Western medicine needs to be open to this and to essentially incorporate this into what's known as integrated medicine. Again, this is a challenge in our environment, but certainly I think anything that makes people feel well should be encouraged. And as I say, we're living on one planet, not in two different universes. And finally, there might be a prize. Well, there's no prize, but does anybody know what this is? Yeah. So there's a lot of interest in this concept of the self-drive or autonomous car. And it's been developed, the technology has been developed by a number of companies, including primarily, I think, Google. I told you they were taking over the world. But the idea is that wouldn't it be fantastic if your epilepsy, because one of the, again, I don't need to tell this audience, but one of the huge challenges of not having your epilepsy controlled is not being able to drive a car. For some people it doesn't matter, but for a lot of people it's a huge issue. So imagine if you had a condition like epilepsy or any other problem that debarred you from driving, that you could just set into your self-drive car and speak into the computer and say, bring me to Powerscourt. I want to have lunch in Powerscourt, and the car goes to Powerscourt. So it's obviously very complex, but it is happening. There are some states already in the United States who are actually passing laws to make these cars legal, but the technology isn't quite there yet. But I really didn't know anything about this until I Googled it. There you go again. So it's but this is amazing, a self-drive car, and I think that would be fantastic if your epilepsy was in control, that you could get into your self-drive car. Okay. Summary: the basic clinical method will remain unchanged. And will become, in fact, more important than ever. Challenges of resources I've mentioned. Don't expect a huge change, and I think the main changes will come in genomic medicine and perhaps also in device technology.